a shout out to Dr. Chad Teven. He's been a mentor of mine, and he helped a lot with this presentation, and will add any additional information, help with any questions that occur, okay? So I'm going to be talking about 3D printing in plastic surgery. Where are we? Where are we going? And what are the ethical implications behind that? 3D printing is rapidly growing in medicine, and plastic surgery is not exempt from this. It provides tactile feedback, real-life spatial sizing, and we've looked at this as to how do you get to a 3D printed item, and to review that briefly is you get a CT or MRI image that then gets converted into a 3D printing program that gets optimized for printing. It gets printed and then inspected for quality and accuracy. So where are we now? There were great systematic reviews that were done in the past, but there was a paucity in the last 5 years. There hasn't been anything that's looking at what we have available. And so we did a systematic review looking at the last 5 years in plastic surgery and 3D printing. And once we had our exclusion and inclusion criteria, we had 16 high-quality articles that we evaluated. Once we looked at them, they fell into 4 major categories: surgical planning, intraoperative use, medical education, and prostheses and implants. And I'm going to go over each one of those and highlight some of the important articles that came out or things that gave me a lot of interest. So to start, for surgical planning, the first one I wanted to talk about is this article from La Padula. This is a study that was done on facial feminization. It's an excellent article that looks at 3D printing, and what it does is it takes a patient's preoperative images and it does 2 things. One, it gives you a hard rendering. That hard rendering went for 3D printing. They printed 2 items. One, they left alone and used it as a basis, and the other one, they did all their osteotomies, their facial contouring, all of those items, and used that in their preoperative evaluation with the patient. The second part to their study, here's that there, what they did, they put their implants on. The second part was using a 3D rendering of the soft tissues and what their surgical plan was for the soft tissues. They used both of these with the patient in their preoperative appointment, and they talked about the complexities of their case, what their surgical plan was, and what they found was this improved happiness and satisfaction in their patients. They did 25 patients, 114 surgeries. The 3D printing took about 4 hours initially with the study to be developed, and then towards the end they got down to about an hour. Their cost was about £150 per model. The other article is a radiology research study that was very interesting. They found surgeons that were doing complex, head and neck reconstruction on the bony skeleton. They approached them and they said, we'll print your 3D printed device, but we want you to look at it and fill out a survey if you think that this is more unique or you saw something that you didn't normally see on the MRI or CT scan, and then also use this in your preoperative consent with your patient. Show them the anatomy, show them the complexity of what's going on. And they evaluated the surgeons, which 5 out of 7 said that they saw something new by having the 3D printed device than using just CT or MRI. And then the patients had improved satisfaction scores and informed consent process on their surveys. Intraoperatively, this study is out of our institution. There's great studies, but the one I wanted to highlight is a little bit different. This is on nipple areolar complex stencil tattooing. And this is a paint by number 3D printed stencil that's provided for the patient. And what this does is this filled a void that these researchers found, which was 21% of reconstruction 21% of patients do not have a pathway to get nipple areolar complex tattooing in the community or in the institution. So the goal with this was to create a paint by numbers, simple technique so that you can easily put the stencil on the skin, put each implant on top of that, and then tattoo around that. So you could create 3D contours by having the Montgomery tubercles or the nipple complex and contour that with different stencils that are placed. The great thing about it being 3D printed is that they've created a catalog of different nipple areolar complexes that are out, and a patient can decide what type they want and then have that 3D printed for the patient. The other great thing about it is I'm no tattoo artist, so it has on it a base layer so you can put the direct amount of depth. The stencil prevents you from going too deep or too superficial. So I think it's been a great study of intraoperative use. This takes 15 minutes in an outpatient minor treatment room. Medical education. I can definitely attest to a couple of these studies on this that have come out recently. So this one, the first one's with sick children. I've used this simulator. This is a 3D printed cleft lip and nose simulator. They've actually come out with more. They have a cleft palate, they have a rhinoplasty. But if you can see from this picture, there's like a headpiece of the child that sits on the table, and then there's independent cartridges that can go in and out of it. In those cartridges, it's multi-layered, independent moving pieces that simulate a cleft lip and nose reconstruction. So you've got the skin. You can go and mark out your skin markings. You can make sure those are correct. When you cut into it, you can see the orbicularis there that you can dissect out. You can remove the cartilage, and there's bony structure. And so this has been super helpful in my training specifically, and I think for future implications for training abroad for our residents, I think it's super helpful. They cost about $250, which I'm glad I didn't know before I started the millions that we've used. But it's a really great device. I think it's helped me understand in a non-threatening way how to do cleft lips and pouts. You can get incomplete, complete, right, left. All of the options are there, and so it's really helpful when you go back on service. The other article is by Lob. This is an interesting one in the sense that there was a PGY4 resident and a craniofacial surgeon that started their 6-month rotation together. They 3D printed different synostoses or mandibular distraction approaches that they were going to do, and they both sat down. They wrote down their written instructions on what their plan was, and then the second part to it was they put their surgical markings on. What they found through that study is that there was an improvement in their surgical plan and an improvement in their surgical markings at a faster time throughout the study. So I think it's an easy way to not do it intraoperatively to move forward in your training. Prosthesis and implants. This is, I think, where we're starting to head more and more, and the articles that came out in the last 5 years are excellent. Some of them that I wanted to talk about was how 3D printing is being used in different ways. So the first one looks at a negative mold, so for rhinoplasty. So for rhinoplasty, they picked out their custom mold that they wanted through their software system. Then they 3D printed the negative of that and filled it with injectable, curable silicone, then sterilized it and put it in the patient. They had good results with that. They felt like at some times that they didn't appreciate the soft tissue motion with that, and they're working through that, but that was an excellent paper on that. The other one was temporal wasting. So you could use the 3D printing to create your negative mold, but then the question is how do you do it when you want to make a custom mold and mold it yourself? So this is where they printed the skull of their patients, and they used methyl methacrylate that they templated on it before surgery. So this is for temporal wasting, methyl methacrylate spacers, and then they sterilize and put it in the patient. And the third one I wanted to talk about was biodegradable scaffolds, and this is, I think, the future of where we're going. This was for maxillary defects. They put these custom-made biodegradable implants in place, and these degrade over the course of 2 to 3 years. They image these patients, and unfortunately they don't have as much bony ingrowth as they had wanted, but it's pushing the boundaries on where we're starting to go on this. And so before I move forward on where we're going, I wanted to talk about the ethics behind this, because I don't think we can have an accurate discussion about 3D printing and innovation without taking a step back and looking at the ethics. So innovation is imperative to our progress, but this does not only mean that improvement equals improvement in care. So how do we implement and monitor innovation? 3D printing has so many advantages to it, but the cost and availability, how do we provide justice and equity of care to our patients? And then individualized medicine. How, if we're doing something that we've never done before, putting in a specific implant, how do we properly do an informed consent with them? So for our recommendations with this, we recommend discussing newness and uniqueness of these devices, frequent outcome and safety review, and self-awareness of bias and conflicts of interest. And now to the future. So 3D printing software is becoming cheaper, faster, and easier. I think Shark Tank just acquired this 3D printing for kids where you can print 3D toys for them. And so it's becoming more acceptable. I saw that you could buy this for $300 online, which I thought was pretty amazing. So 3D printing is becoming more accessible, easier to use. It's coming. And the future is personalized and customized surgery. That's what patients want. It's helpful in the preoperative planning and informed consent process, and we've seen that with the studies that have come out saying that patients have a better understanding of what they're undergoing with their surgeries. Intraoperative guides, I'm sure all of us have used cutting guides and custom plating systems, and medical education. I think cadavers are expensive and they're hard to set up the time in the lab. It'd be so nice if we could print the patient that we're going to operate on and practice the procedure before we go forward. And then implantable devices, there is a lot of basic science research going off on stem cells or osteogenic properties being pushed into scaffolds and having that help with integrating and incorporating in the patient. In addition, they've been talking about chemotherapy agents being placed in the patient that degrade over time to elute that drug more appropriately. And so with that, I say to infinity and beyond, and I'll open to any questions, and then Dr. Teven, if you have anything you want to add.
I'm interested to know how much does it cost to have a 3D printer?
How much does it cost?
For the printer.
Great question. So there are different levels of printing, whether you're a hobbyist printer, recreational, or you want to do this on professional grade or at the enterprise level. But generally speaking, for a printer that is medical grade, between $1,000 and $10,000. If you're a big hospital system, you're looking at anywhere between $20,000 and $100,000. Though costs are coming down, and so that's actually also allowing for increased implementation of three-dimensional printing.
Great presentation, really enjoyed that. So what about for the more common things? Let's say like orbital floor blowout fractures, ZMC fractures. Are y'all 3D printing whatever you're using to reconstruct that? And does it improve outcomes? How's your cost on that compared to bending your old Vitalium plates and whatnot?
So that's a great question. And there are groups that have utilized three-dimensional printing for orbital floor reconstruction, though it seems like that might be overkill for something like that. I think where we are right now is the next step in analyzing this is cost-effective analyses. So we know costs. We can calculate material costs and costs of the three-dimensional printer, but we haven't actually correlated that to effectiveness or outcomes.
So not so much for trauma. For trauma, but definitely for tumor oncologic. That's where it is right now.
Yes, right, exactly right.
I guess for some of these tumor discussions you're having where you're using it for the informed consent process, I'd be curious to know what your workflow is. So patient comes to see you, when does the scan get ordered, how long does it take to print, and sort of how are you using that in clinic?
Sure, so the model comes in after usually during a second or third meeting, because what has to happen is the patients have to undergo CT scans, MRIs, and if it's for a big sarcoma, for example, they've already met with orthopedic oncology, plastic surgery, radiation oncology, medical oncology. So it's a little bit later in the process, but long before surgery. And really, once we sort of have a treatment plan and we know that surgical intervention is going to be advised up front, for example, then we'll go ahead and create the model. But we need those initial scans first to do it.
Hi, thank you so much for the great talk. which was based on a March 2021 paper in PRS Global Open, which everyone can read for free on prsglobalopen.com. My question's a shameless plug, actually. But thank you for the talk and the paper. Can we look forward to more studies on 3D printing and PRS or PRS Global Open from you guys?
I think absolutely. I think that this systematic review came out because there hadn't been really a comprehensive review in the last 5 years. But 5 years ago, there were several, and so it seemed timely. But I think moving forward, right now, there's a lot of research being done, and I would expect on a yearly basis an increase in the number of research publications on three-dimensional printing in PRS and PRS Go.
All right. Thank you.
Thank you.